My task today is to talk with you about pleiotropic effects of liraglutide. This is a very fascinating topic, and after the words of Professor Cosentino, since we have learned from Professor Cosentino that there are no doubts that cardiovascular disease is the leading cause of death for our subjects, for our patients with diabetes. This is true in both men and women, so I don't want to go again in what Professor Cosentino so well discussed and highlighted. But please let me tell you, as a diabetologist, that now we need to consider diabetes as a cardiometabolic disease. Professor Cosentino was very clear. We have to evolve from the glucocentric approach, and we have to recognize diabetes as a cardiometabolic problem. So this is the bad news, but we have also good news. Good news means that we have a friend in that, and our big friend is GLP-1. GLP-1, our big friend, since it's our native human incretin hormone that we secrete every day from the intestine. And GLP-1 is able to reduce cardiovascular disease. Here, on the right side of the slide, you see the multiple concomitant action of GLP-1 on blood pressure, body weight, inflammation, lipids, and of course on metabolism. So these are the so-called pleiotropic effects. But there is even more. On the left side of the slide, see that this hormone, GLP-1, has a direct action on the heart as well as on the. This is extremely important. And this is exactly the reason why we have incretin-based therapy, therapies based on GLP-1. But these therapies are not all the same. There are huge differences because we have inhibitor of the enzyme DPP4, or we have GLP-1 receptor agonists. But again, huge differences in terms of homology. We have therapy based on incretin, found in this reptile in the desert of Arizona in the United States. Or we have the analogs, like liraglutide. Analogs mean that, these agents have extremely high homology than the human native GLP-1, up to 97% in the case of liraglutide. Such high homology means less production of autoantibodies. It means much more affinity to the receptor. In other words, homology is a crucial point of the cardiometabolic effects of incretin-based therapies. I hope that you still hear me well. I really hope so. And liraglutide has for sure multiple beneficial effects. These are so-called pleiotropic effects of liraglutide on different cardiometabolic risk factors. It's amazing how this molecule is able at the same time to reduce A1C levels, systolic blood pressure, lipids, including LDL cholesterol, body weight, albuminuria. It is like a dream. It is like a dream since we wished to have drugs that. What about weight loss cells? This is a smart way to manage weight loss. Liraglutide is able to reduce weight loss at all dosages, 1.2, 1.8 milligrams, even in combined treatments. But there is even more. Liraglutide is able to reduce body weight in all BMI subgroups. It means, in other words, if a subject has a normal weight, or is overweight, or is obese, or even in case of a severe obesity, liraglutide is always able to reduce body weight. And as you can see here in the slide, there is a clear trend towards more body weight reduction. What about systolic blood pressure? Again, this is very fascinating, since liraglutide so quick, in just a few weeks, so quickly is able to reduce systolic blood pressure at both dosages 1.2 and 1.8 milligrams. And this reduction is fast, very fast, but it is stable. It is stable over the time. Reduction in systolic blood pressure. But as we did for both weights, it's very smart. Why is it so smart? Since liraglutide is able to improve blood pressure, mostly in patients with elevated blood pressure, which makes sense. It makes perfect sense for us as clinicians. Here on the left side of the slide, when blood pressure is between 80 and 120 milligrams, then we have such a slightly increase of blood pressure, which means that we have a slight increase in blood pressure in order to compensate, to reach the normal levels of blood pressure, which is very good, extremely good. Then, when the blood pressure is elevated, then there is a strong reduction, and the reduction is stronger when blood pressure is severe elevated, when we have severe hypertension. What about lipids? About lipids, I can tell you that this was extremely fascinating since the beginning. Liraglutide is able to reduce cholesterol, both total cholesterol and LDL cholesterol, and it's also able to reduce triglycerides, and even more than most of all the other anti-diabetic drugs. We found all of these when we started using in my clinic in 2010, years ago, 10 years ago. We immediately found such pleiotropic effect of liraglutide. We didn't want to appear visionary. We didn't want to appear like crazy people. And so we were very cautious. We included hundreds of patients. We did very long follow-up, up to 5 years. But in other words, all of these pleiotropic effects were confirmed in clinical practice. So it's not only clinical trials, but in real daily clinical practice, we see a reduction, of course, in glycemia and A1C levels, but we also do see a reduction in waist circumference and BMI, as well as all these positive effects on lipids, and even more, a progressive reduction in carotid intima-media. At that time, we didn't have the data from cardiovascular outcome trials. So I'm talking about 2010, 2011, 2012. And now Professor Cosentino, a few minutes ago, he talked about the leader study, the study with the use of liraglutide in thousands of patients in both primary and secondary cardiovascular prevention. So about 80% of patients in secondary prevention and about 20% in primary prevention, which is very good for us to know these data. The data are impressive. The study was published in the New England Journal of Medicine in 2016. It was a clear landmark diabetes, since we found that liraglutide had a strong, significant reduction in MACE. MACE means the primary endpoint here, composite primary endpoint of cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. Reduction is impressive, minus 13%, which means, in other words, a reduction of 13% in relative risk to the so-called placebo group. And this was also confirmed in the so-called expanded MACE, when we take into account not only the primary endpoint, but we also include coronary revascularization procedures, hospitalization for unstable angina, heart failure, a lot. It's all the cardiovascular disease that we are worried about. And again, minus 12% relative risk reduction. Confirmed even for microvascular events. Microvascular events were reduced by 16%. So in other words, liraglutide in the leader study, the cardiovascular outcome trial, clearly showed strong, significant reduction in both microvascular and macrovascular events. This is why in 2018, immediately, ADA and PSP put liraglutide the first place of GLP-1s, based on its scientific evidence from clinical trials as well as from daily clinical practice. Just a couple of minutes more about mechanism involved. This is extremely important, since it's not only data, it's not only numbers, but for liraglutide, we have a full story about the mechanisms involved in atherosclerotic plaque progression. There is data that I had the honor to do together with Professor Cosentino, and I will show you very quickly this data. Liraglutide is the only GLP-1 agent for which we have clearly the mechanisms involved in this cardiovascular reduction. This is extremely important. Everything started about 3 years ago when liraglutide was injected in mice, in animal models, and liraglutide was able to reduce the infarct size in mice. Incredible. The injection of a GLP-1, liraglutide, was able to reduce the area of necrotic infarct size. This was clearly totally independent of glucose metabolism. This was due to the presence of GLP-1 receptors, both cardiac and vascular tissues. It's totally independent of glucose metabolism. And this is why liraglutide is able to increase plaque stability, to increase endothelial function. And plaque stability is extremely important. This is the lesson from Professor Libby about 25 years ago. Professor Libby from Harvard disseminated the concept that plaque instability is at the heart of cardiovascular disease. Today, we are lucky to have a Professor Costantino, one of the most outstanding cardiologists on the planet, and he can teach us that stuff are more stable when there is less yellow, less lipids, less foam cells, less endothelial dysfunction. It's extremely important to have a plaque that is stable. And this is related to the presence of small, dense LDL particles. So in order to have less precursors of these foam cells, less foam cells comes from less precursors, less oxidized LDL. We found in 2010 and 2011 that liraglutide was able to reduce so quickly carotid intima media thickness in our diabetic patients. This is not a trial, this is a daily clinical practice. And this was linked for us the reduction in oxidative stress. These are studies that were performed several years ago, but we made a story. We made a story since we found, for instance, here that liraglutide is able to change, to dramatically change the profile from subjects with type 2 diabetes in terms of LDL profile. Before liraglutide, subjects with type 2 diabetes usually have a clear accumulation of red atherogenic small dense LDL particles. This is bad. These are the particles associated to carotid intima media thickness. These are the particles associated to cardiovascular risk. After only 2 months liraglutide treatment, there was such a dramatic reduction, I would say almost a disappearance of small dense LDL. Why this is so important? It's so important since we know now the underlying mechanisms. So GLP-1 receptor agonists have a reduction on cardiometabolic risk, but for liraglutide, we have a clear story about the interaction on plaque formation and integration. This is summarized in this cartoon. This is almost my last slide of the presentation before the conclusion. So please take a look at the green arrows. Liraglutide action at multiple steps of the atherosclerotic cascade. Liraglutide is able to reduce small dense LDL, to reduce oxidative stress here on the left. There is less formation of macrophages. There is therefore less foam cells formation in vitro and less carotid intima media thickness in type 2 diabetic patients with the use of liraglutide. And even more, liraglutide was able to reduce endothelial dysfunction in vitro and in vivo in type 2 diabetic patients. My conclusions are very easy. First, we have to be clear that diabetes has to be considered a cardiometabolic disease and has to be managed, therefore, as a cardiometabolic disease with cardiometabolic agents, such liraglutide. Why liraglutide? The reason is that liraglutide is able to reduce the major cardiovascular events and has multiple beneficial cardiometabolic effects, the so-called pleiotropic effect. So not only glucose metabolism, but reduction in body weight, reduction in systolic blood pressure, reduction in plasma lipids and lipoproteins, reduction of inflammation. Because of all of that, liraglutide is able basically to modify the natural history of atherosclerosis. And this is amazing for an anti-diabetic drug, since liraglutide is able to reduce the formation and the progression of the atherosclerosis. Thank you so much for your attention. Thank you.
Thank you very much, Manfredi, for this outstanding lecture. I've always wondering why do we have a rationale to call these cardiometabolic actions as pleiotropic? Why is this? Because the main action is the glucose-reducing action, or why?
Yes, this is a very good question. I think that this term was used because of statins. So we know that for statins, we like to use the pleiotropic effects when everything is beyond cholesterol. I think that this is why we started to use this term. But I agree with you, Professor Serafinciano. Christian, I agree with you. We should call them cardiometabolic effects, and this makes more the feeling of the power of this molecule.
I believe these cardiometabolic effects of liraglutide are, in fact, its principal or most important effects.
I think that we are now, if I can add something very quickly, we are now in a magic moment for diabetologists, and we are very lucky to have plenty of agents. We will discuss in a few minutes about SGLT2 inhibitors, and we can do such a tailored approach for our patients. Beyond the glucocentric approach, we can try to manage the disease in the right comprehensive way.